great honor that I introduce to you my former partner and teacher, Dr. Michael Klein. Michael has served as the 46th president of the American Pediatric Surgical Association for this past year, and some of his achievements while president include the serious attention to the challenging workforce issues that face pediatric surgery today, about which you have just heard the most provocative, and you will hear more during the course of this meeting. But now I want to introduce Mike Klein, the person. Okay, you're right. Where are the slide advancers? Can you advance the next slide? Don't see. Michael grew up in Cleveland, Ohio. His father, who served in World War II in the Pacific, owned a dry cleaners, and his mother was a secretary. He has a younger sister, Susan, next slide, now retired lawyer for the DOE and present today. As a child, Michael had diverse and somewhat unusual interests. He read, enjoyed chemistry sets, briefly played high school football, and was very active in theater. It is here he first touched greatness. Next slide. Alan Alda was an apprentice at the Cleveland Playhouse, where Michael was a curtain puller. Michael didn't take the traditional path to becoming a surgeon. He began college at the University of Denver, which had offered him a scholarship in 1962. He found himself somewhat disappointed at the lack of intellectual rigor and didn't have enough money to ski, so, next slide, he transferred to the University of Chicago and was introduced to the life of the mind. A transformational experience for Michael. He thought that he would major in philosophy. He graduated from the University of Chicago in 1965. He went on, next slide, to graduate school at Princeton University in medieval history with a Woodrow Wilson Fellowship. Despite the intellectual excitement there, the relevance crisis inspired in many at the time by the Vietnam War turned him to more practical endeavors. With no science background, Michael was initially rejected at several medical schools. So he went back to Ohio, next slide, to the original Western Reserve to work on the process of getting into medical school. To pay for school and to stay out of the Army, he was accepted as a graduate student in chemistry with an NDEA scholarship. And without an application, he made an appointment to what turned out to be the one-person admission committee at now Case. By the end of the interview, Michael was told that he didn't need to apply anywhere else, and thus began his journey in medicine. Next slide. Michael did a summer medical student fellowship in Seattle at the University of Washington, next slide, in public health and preventive medicine. Here, he first touched pediatrics. He went to the homes of children born in the Kennedy Maternal and Infant Care Program to evaluate the children and see if the program made a difference. Back in Cleveland, next slide, Bob A. Zant, an APSA president in 1987, gave Saturday morning pediatric surgery rounds that were the talk of the school and that Mike frequently attended. Mike's eldest daughter, Elisa, next slide, was born the day after he finished medical school at Case. He returned to Seattle to do his internship in surgery. While there, next slide, he took 100 hikes in Western Washington. Although he, the ever-aspiring intellectual, was drawn to the glamour of Boston, and Michael headed to the Harvard Surgical Service at the Boston City Hospital from 1972 to 1977. Next slide. Michael had heard the legendary Folkman stories while in the lab in Seattle and asked if he could spend some time at the Children's Hospital and work in the lab. During the time, he met Bob Langer, who we heard from earlier during this meeting, and began thinking about things other than medieval history, things like immobilized enzymes and tissue engineering and tumor angiogenesis factor. It was a very heady time at Boston Children's Hospital. Mike went on, next slide, to a pediatric surgery fellowship at the Children's Hospital of Michigan, where he was trained by Jack Hertzler, a Boston graduate, Arvin Philippart, and Fred Akari. Michael met and married Peggy, next slide. Don Height played the bagpipes at their wedding, next slide. After fellowship, he served on the faculty at the University of New Mexico, next slide, where Michael has said that Ann Kozlowski, who we recently lost this year, was the best friend and partner that a new attending could have. Next slide. Michael, however, longed for the research life and returned to the University of Michigan to pursue research interests. Bartlett had arrived at the same time, and Michael was drawn to ECMO. In Michigan, his son Andrew was born. Next slide. Michael's third child, Elizabeth, Libby, to many of us, immediately followed. Next slide. Michael was then hired by the Children's Hospital of Michigan as an attending in 1983, where he has been ever since. Next slide. Michael's research interests are eclectic and have included history, publishing on the practice of the surgery in the 14th century, tumor angiogenesis factor, immobilized enzymes, extracorporeal circulation, peritoneal nutrition, abdominal wall defects, robotic surgery, Raman spectroscopy for tissue diagnosis, and quantitative decision-making. Next slide. Michael's professional accomplishments and contributions to children's surgery notably include being the first ever surgeon nominated to be the president of the AAP, and developer of the Organization of Children's Hospitals Surgeons-in-Chief. But outside his scholarly interests, Michael has enjoyed a life of adventure. Next slide. He goes on annual backpacking trips with his son Andrew. Next slide. Has climbed Machu Picchu and Mount Kilimanjaro. Next slide. Recreated Wordsworth's trek across the Alps, hiked the Grand Canyon, next slide, and has enjoyed traveling with his family. Next slide, and I'll just have you scroll through the next few slides. As a father and a husband, Michael has been a hockey dad to both Andrew and Elizabeth, who were high school state champions. There were many nights filling up the backyard water ice rink. Elizabeth now, next slide, is a fourth-year neurosurgery resident at Wayne State and has had the opportunity to operate with her dad. Andrew, next slide, is a lecturer in communications, modern American poetry, got a little bit of that medieval history part, at least somewhere in the family, at Rice University. Elisa, next slide, has been a Broadway actress. She was Frenchie in Grease, and now writes musical comedies and teaches in Brattleboro, Vermont. Next slide. Michael has said the following: most parents love their families, their wife, and their children. I certainly love mine, but even more, I respect and admire them. If I could be more like my wife and children, I would be a better person and a better surgeon. Next slide. Michael is an innovative leader. He is generous with his time and advice. Having served APSA as its treasurer from 2002 to 2005, and having made many contributions, giving pediatric surgeons a strong seat in both the AAP and the Children's Hospital Association. Next slide. It is with great honor that I introduce the 46th President of the American Pediatric Surgical Association, Dr. Michael Klein.
Okay. Fantastic. He's just being kind to my older eyes. Now what did I do? Keynote. Help. All right. A very warm welcome to all who are here. Wait, I can't start like that. Diana, thank you. You'll notice that I specifically chose someone to introduce me who did much better with her career than I did. This is a very warm welcome to everybody here today, especially to you who are surgeons or aspire to be surgeons. My remarks are really addressed specifically to surgeons, but I suspect that anybody else here will find something that they can use. Speaking to the surgeons, you are the best human beings that civilization has been able to produce. You have more walking around knowledge, just plain old memorized facts, than anybody you graduated from high school with. Nobody does this. Your classmates who went to law school, they know nothing compared to you. Every day, you apply that knowledge with clinical judgment to like real human beings. That's like a whole lot different than writing down the facts from an exam because you happen to have memorized them. Not only that, you have to make decisions every day about people. Sometimes they're about life and death. Frequently you have to do it on a moment's notice, but always with incomplete information. And if you add all to that most of you can use your hands relatively dexterously to carry out technical skills at least equivalent to any musician or sports person, it's absolutely remarkable. Now I'm going to give you the clincher, and that's courage. You cannot practice surgery without courage. The courage to be wrong and keep going. You don't have time to sit still and worry about it. If the bleeding starts, you just have to fix it. That's all. And if the diagnosis is wrong, you go and tell the family. And you just go back to work because you still have more patients to see, and you just promise yourself that you're going to do a better job next time. And then whom are you serving with this incredible collection of positive attributes? Children. Children are the most powerful engine for human progress. And if you didn't believe that before, Bob Block convinced you earlier today. That data is in. If we want anything better, whether it's novels or economic progress or basketball players, all we have to do is devote our resources to children, and we can achieve that. I am truly humbled by the honor you all bestowed on me by allowing me to represent you this year. As you'll hear in this talk, I'm certainly not gifted. I know chance or providence had a lot to do with it, but it was other people who made it possible, who inspired and motivated me. Those folks were of many sorts. Most were kind, many were loving, some were really strict, demanding, and insistent on discipline. And I make just slight apologies if I repeat something Diana said, because it's just in my soul that if I'm standing here, I have to mention some heroes. My father, Barney Klein, who returned from the Pacific after serving in World War II. My mother, who after being a secretary became a successful travel agent, and she supported every one of my crazy notions, from theater to ban the bomb marches. My children, Elisa, Andrew, and Elizabeth, whose influence on me will become even more apparent in this talk. They're already squirming in their seats. And my wife, Peggy. Doesn't she just take your breath away? Every day I got to work with her in the hospital. Almost every time I listened to one of her work stories, I learned so much about how to care for patients, how to speak with parents and nurses, how to be careful and accurate. All these are lessons I try to teach the residents, as these are the places so many doctors fall down. It did take me 4 colleges to get a bachelor's degree. But those last 2 years at the University of Chicago, where I discovered the life of the mind, were truly transformative. That's Lester Little. He introduced me to people like Peter Damian and Ibn Rushd. Princeton is a remarkable place. It was way back in the 60s. I got to learn how to read old manuscripts from Gaynes Post, and my poor daughter had to learn what quod omnis tangit omnibus approbator actually meant. She can tell you, you can see her tonight. Larry Stone later became chairman of the department, taught me about Tudor Stuart England. It's absolutely incredible, but Vietnam did have its influence, and I did go to medical school. That's Cactus Jack Coy, that one-man admissions committee who let me into medical school. Larry Weed was at Western Reserve then. He's the guy who came up with the idea of the electronic health record before there was even a personal computer available. And he taught us that medical records can actually guide and teach. Walter Porres was the brand new chief of surgery at the old Metropolitan General Hospital. I had 1 rotation on her service, and oh, gee, I should be a surgeon. And then there was that tiny little auditorium at B&C Hospital where we all snuck in to hear Bob Izant's grand rounds. That was fantastic. My last 3 months of medical school were spent in Serbia. After 2 weeks of lectures in Belgrade, carefully looked over by the image of Marshal Tito, I went off for 6 weeks to the village of Petrovac na Mlavi to learn how to measure the level of health. I actually took part 2 of national boards in Belgrade and learned that I'd matched to Seattle. Seattle was like really okay. Gene Strandness let me operate. D.K. Clausen was chair of orthopedics. He was a real taskmaster. But what he taught me about chronic back pain in adults, I use every day in the management of chronic abdominal pain in children. It was remarkable. At the Children's Hospital, there was Lester Savage and Peter Mansfield. They're incredible people. Of course, the most impressive, as always, was my chief resident, Bill Brenham. Still, each one of those rotations was only a month, and I was, quote, disappointed with the program. I could really be an arrogant ass. I suppose I still can. So I transferred to the Harvard Surgical Service at Boston City, where my arrogance was again demonstrated, but this time I dealt with it more maturely. I applied for 2 years at Boston Children's. I spent a year in the lab and a year on the wards. You've already heard from Bob Langer. Ken Falterman was my partner in the lab. We would have to hold the rabbits for each other. Every Monday, Wednesday, Friday, we did slit lamp examinations on 60 rabbits to measure the inhibitor in the rabbit's cornea. We spent 3 days with the photographer hoping to get the cover of Scientific American. You can tell that we lost out to fireflies. But we did get a full-page picture on the inside. The clinical year was actually more astounding. Tad Ballantyne had been my chief resident at Boston City and was my chief resident once more, a talented, generous, compassionate surgeon who died too young. People at Hershey still talk about his abilities to teach. Bob Filler, Arnold Kolodny, Sam Schuster were not only role models, they let me operate. How could you not want to be on call every other night and every other weekend? When I returned to 5 Surge, we'd been evicted from Boston City, and we're now headquartered at the New England Deaconess Hospital. I spent 8 months on the service of Bill McDermott and Frank Wheelock. Dr. McDermott did a lot of portal hypertension surgery. I learned a lot about bleeding, but Frank was the busy one. Frank was a tall, gaunt New Englander, a transatlantic sailor, a meticulous surgeon, and literally feared wherever he went in the hospital. He was also my foster father in surgery. I lived with him and Nancy in their home during my chief resident year. When I was deciding where to apply in pediatric surgery in that first year of the Brad Rogers match, Dr. Kolodny told me, Jack Hertzler has done more Hirschsprung's disease than anyone in the country, and now that Arvin Philippart is there, that's the place to go. It was all true and more. There was so much to learn from Pete Gibson, Fred Arcari, Pat Jewell, Hans von Berg, and it was the home of Cliff Benson, who wrote the textbook that I've been reading to try to prepare for this. Arvin, as you all know, was the central figure. In addition to operating, there were important things going on at the hospital, like changing dressings in the burn unit. That's Peggy. We were to spend the next nearly 40 years as children's hospital people. My first job in New Mexico with Ann Kozlowski, whom you could only know and love, she taught me many things, including how to ligate a PDA. But I still had academic aspirations, and when Arnie Koren asked me to offer a job with a laboratory and a chance for Peggy to be back with her family, I had to go. I arrived the same year as Bob Bartlett. Of course, he was a full professor, and he played such an important part in my career, as you all know. Another unsung hero was Bob Drongowski. Bob is a finisher. He can take a research project from beginning to end, whether it's his or someone else's. He's also a social activist and a very good fisherman. When Jack Hertzler retired from operative surgery, Arvin called to see if I would be interested in returning. He's certainly a hard person to say no to. He also offered, hey, let's start an ECMO program, and we'll give you a laboratory, and oh yes, I'm here by myself, and there's a few cases to do. It was really fantastic. I thought I would just show our president-elect in her stint as fellow and partner. And if you don't recognize him, that other Detroit APSA president, Keith Jorgensen, during his fellowship. No recitation of important persons can be complete without those most responsible for my education and who were the focal point, as well as the greatest joy of daily life at CHM for Arvin and I, the pediatric surgery and critical care residents and fellows and my partners. Any research I was able to accomplish was made possible by collaborations. Here's Grant Whittlesey, who was the perfusionist who really started the ECMO program and ran our lab for 10 years. And in engineering, I found other collaborators, not quite as productive as Langer, but we've done some things. Steve Sally in chemical engineering and Abhilash Pandya in electrical and computer engineering. The Children's Hospital of Michigan doesn't even look like this anymore, as a new patient tower goes up and several new outpatient buildings have been constructed. Special appreciation has to go to our current Chief of Pediatric Surgery, Christine Ashanti. She is an elegant surgeon and a creative leader. And to our current Surgeon-in-Chief, Joe Lelly, whose management skills are only surpassed by his abilities in minimally invasive surgery. With no language but a cry, children are asking for better surgical treatment of their ills and are begging for more thoughtful attention to the congenital deformities it was their misfortune to be born with. Willis Potts wrote this sentence in the introduction to his 1959 book, whose title I have borrowed for the theme of this meeting and the title of this talk. He was demanding specialization in pediatric surgery. This shows how we have answered that cry. When I applied for Pediatric Surgery Fellowship, there were 14 training programs in the United States and Canada and fewer than 250 pediatric surgeons. Today, there are 53 training programs and nearly 1,000 pediatric surgeons. Yet the number of children with congenital anomalies and solid tumors has not changed. As Ron Herschel has pointed out, the average pediatric surgeon recertifying today after 10 years has done 9.5 index cases in the last year. I reviewed a lot of workforce papers in preparing this talk. I found 12 papers that tried to present data. Every one said there were too many pediatric surgeons. To avoid singling out any one of the living authors, many of whom are in the audience, I'll go back to the first workforce study by Mark Ravitch. 300 general pediatric surgeons will quite easily carry the load, and with more, there will be a decline in the operative, diagnostic, and therapeutic skills. Pediatricians and parents demanded that pediatric surgeons operate on children, and we have responded. But if there's going to be a pediatric surgeon to do every appendectomy and drain every abscess in a child, are we going to be any good at biliary atresia? At our meeting in 2013, Keith Oldham made it clear that pediatric surgeons did a better job of taking care of children. The data presented was based mainly on common procedures, as there are not enough index cases to get good statistics, and in fact, not enough non-pediatric surgeons were doing index cases. In addition, they focused mainly on institutional data and outcomes. We all agreed that the data and expert opinion overwhelmingly support the premise that systems of care designed for children provide better outcomes for children. The membership of APSA supported optimal resources for the surgical care of children, and it's now incorporated in the verification process at the American College of Surgeons that's in the alpha phase of implementation. Now let's return to the surgeon who may do one particular type of complex case only every 3 to 4 years. For years, we told ourselves stories to explain why this was okay. We do rare stuff. You know, that's tough, but we're tough. Our operative skills are kept sharp by our large volume. Each different operation employs the same repertory of skills. Thus, we can easily turn from biliary atresia to hepatoblastoma. Now, I'd like to examine the truth of such statements. I don't suspect I need to introduce the gentleman to your left on this slide. On the right is Tad Ballantyne with Dr. Gross's last scrub nurse, Beth. They are working in that very operating room where Dr. Gross hung that now famous sign, "If an operation is difficult, you are not doing it properly." I must respectfully disagree. Some operations are really difficult. You know which ones they are. They're the ones where dissection is required and the tissue planes are only subtly revealed. You know, if you have to do an ileoatresia and you want to lop off that distal dilated end and create an anastomosis, that requires knowledge, skill, judgment, 2 years of pediatric surgery fellowship, but it is leagues less difficult than finding the correct plane on the rectum for Hirschsprung's or imperforaneous the first time. And it's leagues more or less difficult than trying to resect an abdominal neuroblastoma. I'm going to leave phase 1 of this talk with what's going to be the take-home message. Surgeons learn to operate while operating with a coach and with effort. That, the composer, not the violinist, was Paganini, unquestionably an expert. Actually, it's thought that he wrote pieces like that because he thought he was the only one who could play them. Sometimes I think surgeons invent operations that way, too. We're going to start talking about expertise in general, and then medical expertise, and then finally operative expertise. So if we're going to talk about expertise, we have to start, some people say end, with K. Anders Ericsson. and his colleagues and disciples. Ericsson's theories are based on research and experiment. He didn't make them up out of whole cloth. Perhaps the most important finding is that there is little or no evidence of giftedness. No one is born a great musician or a great surgeon. From my viewpoint, even if giftedness did exist, it would be irrelevant, because there just aren't enough gifted surgeons to do all the operations that need to be done, and the rest of us have to, learn how to do this stuff. Expertise is acquired by deliberate practice with a coach. In most cases, it takes 10,000 hours or 10 years to acquire. This is of some concern, since the average general surgery resident spends only 2,300 hours in the OR, and the pediatric surgery fellow, by adding another 2 years to her training, will still have spent less than half the 10,000 hours. It is important that the practice be deliberate. It matters how effectively you use your time. As one air traffic controller has said, after 7 years of experience, some become experts, and some are just 7 years older. I know you've never said that about one of your fellows. This is like real brain work, okay? And work requires energy. This is one of my favorite psychology experiments of all time. They gave people an incredibly difficult mental task, and half the group had to drink lemonade sweetened with sugar, the other half drank lemonade sweetened with Splenda, and the group that got the glucose that fuels the brain did better. Think about that when you have a cup of coffee before your next case. Deliberate practice also means breaking the task down into elements and practicing each element. In addition, one must stretch. You have to do things that you can't do well, or perhaps even at all. And another key point, the people who are going to be experts are the people who love the practice. The coach is crucial. Experts are able to recognize and find good coaches. Some can even coach themselves. But there's some new things on the horizon. Thomas Lenve is a pediatric urologist, and he used the Amazon.com's Mechanical Turk and Facebook crowd workers to judge skills of residents videotaped during surgical exercises. They were just as reliable as the surgical faculty. Greg Hager at Johns Hopkins has combined tracking surgical tools with tracking the surgeon's eye gaze and created software that allows a computer to judge surgical skill with 82% accuracy. Let's consider our own coaching skills. The prevailing apprenticeship model of training surgeons is probably not the best. Richard Clark spent a career at USC doing this. He demonstrated that experts omit over 50% of clinical knowledge and technical steps when teaching in a non-structural manner. He has created a method of cognitive task analysis to correct for this in how we construct teaching modules. Richard Resnick in Toronto has done similar work in creating the objective structured assessment of technical skills. It turns out that test taking is a really important part of learning. I think because it's really a form of coaching. I found 16 good articles evaluating deliberate practice with a coach in the surgical literature, and in every case, of course, they got better results. Now let's talk about medical expertise. It's usually thought of as diagnostic expertise. We've already learned today that better diagnosis could be important. The current wisdom is that an expert has memorized a great number of illness scripts which she can call to mind and test against the current task. There's a psychological theory to explain this now. The current one posits something called long-term working memory. We all know about short-term working memory. At the most, it can contain 7 chunks. Usually it only contains about 4. Long-term memory is okay, but it requires about a second to access. And long-term working memory sits in between these and has cues to what's stored in your long-term memory. Gary Klein has studied the expertise of firefighters using these ideas and notes that they seem to have a repertoire of patterns, both real and virtual, they're not all from experience, which they evaluate with mental simulation, comparing them back and forth, and it allows them to modify their actions. Thus, an experienced firefighter just knows when to get out of the building. Well, it clearly takes time to acquire enough illness scripts to become an expert. And interestingly, novices actually reason differently than experts, and you can see this on functional MRI. Novices tend to reason directly from basic science. They often do better on standardized tests than experts. For instance, given a list of laboratory values, the medical student can memorize just as many as the nephrologist, but the nephrologist will have remembered more of the relevant ones. This background makes it easy to understand how one expert can be more accurate than another. Paul Meehl worried about which expert to trust, and he's the first one who really brought to our attention that following rules or algorithms was more likely to reach a correct conclusion than following the judgment of most experts. That's my response. Terrifying. These differences can be explained using System 1 and System 2 described by Daniel Kahneman in Thinking Fast and Slow. System 1 is the automatic thinking we use in everyday life. It requires little or no effort, but it's constrained by many biases. The most important bias, and certainly the most common, is what you see is all there is. So here's a really great example. We're going to describe Steve as a meek and tidy soul. And then I'm going to ask you, is he more likely to be a librarian or a farmer? Everybody thinks the first thing you think of is a librarian. So now we're going to employ and engage System 2, that's effortful mental activity. Who knows? We might even go look it up in a book. No, I'm sorry, on the computer. Okay? And if we did that, we would discover that there are about 58,000 male librarians in the United States, but there are about 3 million male farmers. So no matter what the personality characteristics, he's much more likely to be a farmer than a librarian. Experts use System 1, which is why one of the major differences between experts and novices is speed, not accuracy. But experts may trust their System 1 too much and too often. To become experts, novices need to build scripts. That is, they need to see a lot of cases. Algorithms level the playing field. I really predict that the electronic health record is going to enable us to use algorithms more often, and they will probably end up improving our diagnostic expertise. So to bring this home, let's consider wine experts. One can spend years developing knowledge and expertise in wine tasting, and you get to drink a lot of wine no matter how much spitting you do. That's how these guys were able to choose the California wines over the French wines. Or you can employ the formula developed by Princeton economist Orley Ashenfelter, which uses the average temperature during wine growing season, the amount of rain at harvest, and the total rainfall during the previous winter, and you get the same results. All right, let's talk about operative expertise. The current best theory that people use of motor skill acquisition is that of Fitz and Posner, which describes the three phases. There is the cognitive or verbal motor. That's when your dad is teaching you to drive a stick shift and he tells you what to do and you move your hands around. Then you get to the associative place, and that's where you can actually do some teaching yourself because you've memorized the steps, and if you do something wrong, like try to move the gear shift lever without stepping on the clutch, oh yeah, I know that's the mistake, I know how to correct it. And the third is the autonomous. Now you can make phone calls and eat a Big Mac and still keep shifting. Some people call this muscle memory. If you are one of our basic scientists and would like some neuroanatomical and physiological correlates demonstrating that this is actually true, here's a very convincing paper that was just put online. I'm sure it will be in print soon. The question arises as to what one must do to retain these skills once learned. Are they all like driving the stick shift or riding a bicycle where it's supposed to just come back to you? Let's go! So Elisa and her fellow cast members did that 8 shows a week for years on Broadway. I'm sure they could do it in their sleep. But if we put them up here right now, I think they wouldn't be quite as polished. The Army has studied this, and some of their findings are these. Retention of motor skills depends on a lot of things. The most important is how well you learned it the first time, okay? But there's also the length of time that you haven't practiced it, the type of task it was, the interfering activity that you were doing when you weren't doing that particular skill. Still, the time to relearn is less than half the time it took to learn in the first place. And some of the factors that decrease the length of time to relearn include test taking, augmented feedback, and the functional similarity of the training device. In fact, I think the military is a good example of a field where expertise is essential, but employed only seldom. Sean Stafford was one of our fellows. He was a Navy SEAL before he went to medical school. So I called him up to ask him, how do you guys stay sharp, even though you don't do this maybe ever, or maybe you do it once every 12 years or something like that? So in his modesty, or maybe it was secrecy, he chose to tell me about his brother instead. So his brother is a police officer in Hamilton, Ohio. Okay, he was called to the scene where a man was waving around an AK-47. He asked him to put the gun down, and the guy shot at him instead, grazed his scalp, blood was pouring down, blinded his right eye. He pulled out his sidearm and ended the situation. He was like the hero, okay? So if you talk to people who know about this stuff, and I certainly don't, that was an incredible shot to make at once, standing up in the line of fire. It's not something he does every day. He was only able to do it because he trained and retrained and retrained. Frank Spencer is said to have been the first to remark that motor skill or manual dexterity is only 25% of operative skill. Let's just call that one part. You know, for me, the other parts are recognition of the objects in the field, judgment or decision making, and the knowledge required to implement that decision. Ericsson has said that surgical expertise is not a matter so much of technique, but of anticipation or reaction skill during surgery. This has been called recognition-primed decision-making. Faced with a pre-duodenal portal vein at operation, the surgeon first has to recognize what the heck it is. She has to have the knowledge of how best to treat it. She must be able to make a decision as to which treatment is appropriate in this case. Maybe nothing. Recognition can be trained, especially when separated from the full recognition, decision, action sequence. Peter Fatty has used techniques of temporal and spatial occlusion of the visual field to accomplish this. By occluding a baseball hitter's vision of the pitcher at different times, he figured out that the only thing that counts is when the ball leaves the pitcher's hand. You don't have to look at anything else. And if you do that, the hitter is going to be able to recognize the pitch. And he's demonstrated that not only can he improve the hitter's batting average, he can improve the team's win-loss record. We may be able to use this kind of technique to train surgeons in what I alluded to earlier as the most difficult part of an operation, finding the correct surgical plane. just like Ed Kiley taking a neuroblastoma off the great vessels with a scalpel. Simulation has already taken a big step towards this goal, but it can be refined even more. For the action components or motor skills, low-fidelity simulators like laparoscopic box trainers work just fine. For the recognition component, higher fidelity is required, such as videotapes of specific procedures and then asking the student to recognize missteps or better approaches. And let's face it, skills do not transfer unless the task environments are very similar. Michael Jordan was a better baseball player than I could ever hope to be, but he was still much better at basketball. So once more, surgeons learn to operate while operating with a coach and with effort. The more you do, the better you get. I reviewed 35 papers that investigated individual surgeon volume. All found better outcomes with high-volume surgeons. So, with fewer cases, can our fellows be trained? Can we maintain our skills? The data says no. So, let's consider. Have we already achieved operative excellence so we don't have to worry about this? Not yet. Atul Gawande, in one of his very early studies on surgical adverse events in Colorado and Utah, found that 66% of all adverse events were surgical, 54% were preventable, and half of all the surgical adverse events were technique-related. What is APSA's role? And by APSA, I refer to the community of pediatric surgeons in the United States and Canada. Last August, I called together a task force of 40 pediatric surgeons representing every constituency I could think of. I apologize if I didn't invite you. We met at AAP headquarters in Elk Grove Village, Illinois, with a professional organizer facilitator. We gave Aaron Jensen, a pediatric surgery fellow, the award for the best contribution. We came up with 3 basic conclusions. 1, pediatric surgeons should operate on children. Surprise. 2, we will support training programs being required. To provide adequate volume for training. 3, we will work closely with general surgery to develop the next practice model. If that's not plain enough, I'm going to put it this way. We are not willing to hand over children's operative procedures to general surgeons who specialize narrowly in something like thyroid surgery. The next step is going to be the colorectal surgeons. Your APSA Board of Governors agrees that the current proliferation of training programs and the current low-volume index case practice are not in the best interest of patients or their surgeons. In my view, in the near term, our solutions need to be congruent with 2 things: the optimal resources for children's surgery document and the current evolution of training in general surgery, which is very likely to go to a 4+ model with 4 years of general surgery followed by a variable number of years in something like rural surgery or minimally invasive surgery. Thus, I can envision training 2 sorts of pediatric surgeons. A pediatric general surgeon would practice at an optimal resources level 2 center, although her services would definitely be needed at level 1 centers as well. That means she operates on children of any age who are ASA 1 to 3, and specific operations would be surgeon volume based, but they would certainly include real pediatric surgery, NEC, abdominal wall defects, malrotation. The second sort of pediatric surgeon would be a pediatric specialist surgeon. This pediatric surgeon would practice primarily at a level 1 center, serving patients of any age and any ASA. Again, the specific operations would be volume-based so that not even every one of these surgeons would do every operation. As Drs. Langer, Gordon, and Chen presented at this meeting, the surgeons operating for CPAM would not necessarily be the same ones who took out thyroid nodules. And frankly, I'm not sure the transplant surgeons should be doing appendectomies on perforated appendicitis. I do not think the distinctions should solidify into new specialties, but rather they should vary with local circumstances and abilities. Now, I know people are going to be concerned that this is going to create two classes of pediatric surgeon. I'm not really sure that it will. I think there'll be two different kinds, but it will allow us to fulfill Dr. Pott's dream of ensuring that every child is operated by a children's surgeon. Let me draw one more example from my family. Andrew earned a PhD from the Department of English at Rice University, where he now teaches. The English department there consists of professionals with research and writing careers that are highly specialized. They talk about things like semiotics and the work of Roland Barthes. They represent our pediatric surgeons who are doing basic science research or liver transplantation. But that same English department has an obligation to teach all the undergraduates, many of whom are engineering students or pre-med, how to read and write effectively. To accomplish this, they have created a program in writing and communication. Now, this is where Andrew teaches. He loves teaching undergraduates to appreciate literature, see its applications to their life and work, and learn to write in a way that communicates their thought and feeling. The people who teach in this program really enjoy what they're doing, much more than the English department faculty would ever like that kind of work. Now, here's a key point. Faculty members in this program may soon be on a tenure track. That is, they will receive recognition as a valuable part of the university community on a par with any other faculty members. I submit that there are many pediatric surgeons who want to do hernias, appendectomies, NEC. They don't want to have their heart in their throats as they try to pass the gastric tube from the chest into the neck or isolate the hepatic veins, especially if they haven't done it for 6 years. My daughter Elizabeth works with neurosurgeons who never want to clip an aneurysm or resect an acoustic neuroma. I believe there are residents who want to be general pediatric surgeons and that their education and practice can be structured to provide excellence for patients and professional satisfaction for the pediatric surgeons. Both the general pediatric surgeon and the specialist pediatric surgeon can be on the tenure track. Research is going to be needed as we struggle with things such as what minimal numbers should be. Steve Kasten is a plastic surgeon at the University of Michigan, defined this as the number needed for 90% of residents to do a case independently without an above average number of complications. God knows how we'll ever figure that out. However, we do have numbers that we can get, such as the plateau of the learning curve. Now that can be very high. It's reported to be 60 for laparoscopic liver resection. And survey and expert opinion may not always be the best judges. My favorite one is, in general surgery, you have to do 35 upper scopes to be allowed to do them by yourself. You know, the GI people make you do 130. Somebody actually studied it and they found out that 35 is really enough. So there's a lot of organizational, administrative, and leadership work to be done. What can you and I do? We can incorporate deliberate practice with a coach and with effort into our training programs and our daily practice. We can read just one article by Richard Clark or Richard Resnick and structure the way we take a resident through a case. We can use the simulation center not just as a place to send the resident, but as a place to hone our own skills, and especially to warm up before an operation we haven't done in a while. Warm-ups work. That data is also in. If you don't know exactly how we can do that, you should take a look at the work of Max Mazels, another pediatric radiologist. He and his associates have created this computer-enhanced visual learning program. You can just Google CEVL, a little 20-minute video that will get you going when you haven't done that case for a few years. Pediatric surgical expertise is in danger of declining. If that occurs, it's going to be difficult to detect. Unlike carotid endarterectomy, it's crystal clear there that if you do more cases, you get better results. We just don't have enough of any one case. But even though it's going to be hard to detect, it'll still be of great importance to our patients and their families. Surgeons learn to operate while operating with a coach and with effort. Pediatric surgery must address workforce as an issue of clinical competence. I urge us all to do the research, to take action, and to study the outcomes. I may be channeling Arnie Salzberg because I'm referring to Rabbi Hillel here. If not me, who? If not now, when? We have the expertise. It is our responsibility to provide children with expert operators. I urge us all to do the right thing. My grandchildren and their children join me in thanking you for pursuing this noble undertaking. Thank you.